Wonderful. Well, it's a great honor and pleasure to be contributing to the conference and to this panel, and I'd like to thank the World Diabetes Federation and other organizers for inviting me. It's very good to see so many friends and colleagues, and also to listen to some of the important contributions from the earlier panel, which this panel will build on. So we have a stellar panel. Oops. I'll read my notes. We have 4 panelists. We have Erika Placella, who's head of health at the Swiss Agents for Development. I'll be brief in introducing the panelists. Secondly, Elisa Morant, who's head of program at the World Diabetes Federation. Mats could not join us due to a family problem, unfortunately. Then we have James Reed, who's program officer at the Helmsley Trust, who oversees grant and the programs for type 1 diabetes, and Stephanie Pearson, who is Senior Director of Global Responsibility at Breakthrough Type 1 Diabetes. So this panel is co-chaired with my good friend and colleague, Professor Dr. Jean-Claude Mbanya. We'll initially have the panelists to each present for about 6 to 8 minutes. I know you were told 10, but our time has been cut back, regarding their organizations, what they do, what they're contributing, what impact they're having, and how they're collaborating with others. Then we'll have a round of questions that my colleague Jean-Claude Mbanya will read. Then we'll have another round of questions, which I will read. Then we'll open the floor for discussion, to have a free-flow discussion and contributions from the floor and panelists. So without further ado, I'd like to invite our panelists to join us at the table. I'll start with Elisa Morandat to talk about the contributions of World Diabetes Federation. Then we'll take turns.
Thank you very much, and good afternoon, everyone. I think throughout the last 2 days, we have heard quite a lot from partners that the World Diabetes Foundation, not Federation, has supported. So I thought I would focus today's intervention, given it's about the international partnership, more on our approach towards partnerships. I think I want to start by bringing us back 20 years ago, in 2005, when you had the Paris Declaration on Aid Coordination. And why am I bringing that up? It's because there were 5 key elements, which I think guiding principle and which we have heard already quite a lot. National ownership was one of them. We've talked about national leadership, but that's along the same line. Alignment, harmonization, managing for results, which for us means stronger health systems able to provide improved care for patients living with type 1 diabetes, and then mutual accountability, which I think also has been high on the agenda, and here it's mutual accountability of local partners and us as donors towards, of course, patients living with type 1. And these are still very much relevant, especially with an increasing number of non-traditional donors, like private foundations like ourselves, or programs from private companies that we've heard from before, and so the more non-traditional donors. So there's no doubt that we've seen the last 2 days that the task ahead of us is still huge, but there's many steps that have already been taken into the right direction, and especially now having type 1 diabetes well reflected in global framework approaches, which was not the case just 5 years ago. So at WDF, we have, when it comes to type 1 diabetes, it's the integration into national health system. That's our core contribution. I'll come back to that. And then also in terms of approaches is the coordination, which has been talked a lot about. It goes hand in hand with collaboration. And it might not be bold or sexy or whatever you call it, but we all know it's very much needed. And it's sustainability that we have in mind, but not only as an end goal, but really as a means also. And that's why, for instance, in our approach, when we support partners, WDF does not fund incentives for healthcare professionals, for instance, because, again, that will not be sustainable in the longer run, just to give an example. And you could say that those 3 aspirations, they are shared by all of us, but each organization have different comparative advantage, right? So, and none of us can claim or pretend that alone we can reach any form of sustainability. So it will always be joint effort. And also we keep on hearing about specific models, but at WDF we also very much know that needs might be similar, but the landscape, the context in each country is so different. So you need a proper understanding, a proper stakeholder mapping as well to start with. And integration, again, it's one of those buzzwords or integrated care that you hear a lot. And we all know that implementation is much messier, right? And it's much easier said than done. And those terms need to be unpacked in specific settings. So how do we ensure also that integration, keeping in mind this has been said that type 1 diabetes doesn't get forgotten or it doesn't get diluted in the broader diabetes and even broader NCD agenda. And again, I will not come back to some of the examples, but I just want from tomorrow's also panelists, we've heard that we can't have the full integration to start with. We need to start with small steps. And this was said by a panelist from Pakistan this morning. And these are important because this is the art of the possible. We talked about the data, for instance. So if I give the example of Rwanda, and we've heard also about it, regarding having electronic capture of patient data, this is an electronic health system that we have supported. It's not yet integrated into the broader system, but why is it important? Because it provides, as was mentioned by the former panelists, it provides some data that we can work on. Of course, the goal will be to have it fully integrated in the broader system. And I think also to go back in terms of the coordination and collaboration, what I think many of us in the room have appreciated throughout the last 2 days is it's a frank dialogue. Implementation is difficult, and that mutual accountability, it's important between partners that we're able, of course, to talk about the results we achieve and the progress we made, but we're also able to talk about the issues and the barriers we faced, and we need to recognize that. And I think this was also mentioned by Sana yesterday, that, I mean, there are issues and it needs to be talked about and recognized so that we can progress. So I think that's the thing in a nutshell that I wanted to highlight, and the three things really was the sustainability, the coordination, this integration in national health system, given that you have already heard a lot of the example from those countries. Thank you very much.
Wonderful, thank you for these, for the great contributions. I just want to summarize very briefly. It's the first time I heard, compared to the other panel, that you mentioned some of the principles from Paris principles or Accra principles, sort of mutual accountability, and I think it's very important that type 1 diabetes community transitions to being part of the sort of global discourse and some of the principles that have been in place actually for almost 20 years. So it was really great to hear that. And integration, maybe just to mention integration, we use it very simplistically. It all depends what you're integrating with what. And it could be integration at service level, it could be integration of medical records, it could be integration of planning, financing. It would be useful really to unpack what is being integrated with what, at what level, and not to approach that very simplistically. So just a heads up for our next panelists, Erika Placella, who's head of health from the Swiss Agency of Development. Erika. The floor is yours.
Yes, thank you very much. Good afternoon. I feel that a lot has been said, and this is maybe redundant, but thank you very much for the invitation to give the government donor agency perspective. I have the feeling I'm the only one representing a government agency here in this meeting. I think it's important that government agencies and international cooperation and ODA also, integrates NCDs in its strategy, health strategy. So, first of all, as I said, we consider that NCDs are a serious challenge for the sustainable development of low and middle income countries. We've talked about the Paris arrangements, but I would like to put on the table the Agenda 2030. Nobody talked about this. Of course, someone mentioned that 2030 is soon, will be soon, we will reach it, and we don't have a target, but still, NCDs were part of the Agenda 2030, so they are a development issue, and 82% of premature deaths from NCDs, they occur in low and middle income countries. So it's also clearly demonstrated that poverty drives and is driven by NCDs. So it's a question of equity, it's a question of reduction of poverty, and these are international cooperation buzzwords since many years now. So it has to be part of it. And we also know now since COVID-19 that the risk factors for NCDs can make people more vulnerable to becoming ill with pandemics such as COVID-19. So donors who are now very much into pandemic preparedness and response, they should also know that there are, about the risk factors, and people are more vulnerable if we don't integrate, don't address NCDs in every single PPR effort. So it's also part of the PPR agenda. And now, yet, you know, is that it has been mentioned many times during these 2 days, but the resources for addressing, I'm talking here about the financial resources for addressing NCDs, they are inversely proportional to the global burden of disease. I mean, this is a reality. It's even worse after COVID-19. Because it has been also exacerbated by the huge resources required for the COVID-19 response. And now, PPR efforts and mobilization of resources, being it the pandemic fund or the global fund, and etc. So everyone now is interested in PPR without thinking about the fact that NCDs are also part, in my view, of a comprehensive, cost-efficient and cost-effective PPR prevention, preparedness and response. So, because we are aware of these challenges, Switzerland sets its priorities and designs its interventions accordingly, and by making bold investments in addressing NCDs, and it includes mental health. So we consider that mental health is an NCD and it has to be addressed, in the same package. Now, together with the Russian Federation and Kazakhstan, Switzerland is one of the major donors addressing NCDs in the Eastern Europe and Central Asia region. We started in Africa, but it's much more complicated. We started in the Great Lake region, but I think there is still some more work to be done when it comes to strengthening health systems in sub-Saharan Africa. So now, what do we do? At the global level, this is a multi-level intervention, approach. It's not just about making drugs available. So it's at the global level, at the normative level, because we need norms. This is why I was asking this question about to what extent your evidence feeds norms, because we negotiate those norms and arrangement in UN fora, including at WHO. So we support, for example, we supported in the past the GCM, maybe some of you, the GCM NCDs, I think you were, Professor, you were because I saw you there in one of these working groups. And then the development of the PEN protocols at the beginning, we supported that. And then, and FIND, colleague from FIND is here, to develop the point-of-care devices for testing cardiometabolic diseases and diabetes. And in addition, with the University of Geneva and David, we are currently exploring ways to support pool procurement mechanisms for insulin and associated devices. I will come back later on our approach and instruments used for addressing these challenges, but just the 4 components of a comprehensive approach of an intervention. What is the intervention framework, which is comprehensive and really addresses NCDs in a broader manner, in a broader way than just addressing it horizontally? It has also been mentioned by other colleagues. First of all, you have to change the narrative. I know this is humiliating for some of us working on NCDs since many years, but still, from the donor perspective, there is still the need to demonstrate that there are huge costs of inaction if you don't address NCDs. And I met Gauden Galea this week. He was telling me about the case for investment for Ozempic, and he told me, if you are able to explain what are the economic costs of not having Ozempic, then you can use the same case for investment for investing in primary prevention of NCDs. And I told him, wow, this is great. I will integrate it in my narrative. I mean, trying to convince all the donors to, so there is still a lot to be done, as I said, and we found that using the inequity lens, it is easier. And a lot of evidence you brought here these 2 days, it can be reformulated with an equity lens, you know. It's inequitable. What is not affordable is inequitable. There are huge inequities, human rights, and etc. That narrative, not just this scientific evidence. You know, you have to combine different narrative. Then carrying out a strong policy dialogue and advocacy work. It's not enough from our perspective to support projects in countries and procurement mechanism, etc. without a strong policy dialogue. I mean, and we do it in a VOGA way. Together with Swiss stakeholders and Swiss health system also working in NCDs. I'm going to go faster, maybe. So we combine policy influencing, policy dialogue, advocacy with interventions in the country. These interventions, we use them, being it in Albania, Moldova, Kyrgyzstan. There are 2 colleagues from Kyrgyzstan here who know about the NCDs project we supported in Kyrgyzstan. So we use that evidence and we bring that evidence in UN fora. Otherwise, it's just diplomatic blah, blah from our side, you know? So we need that evidence. It's about evidence-based, science-based policy making. Then at the country level, we take a holistic and comprehensive approach. This is not just about procurement system, it's about strengthening the health system and integrating NCD's functions at the primary healthcare level and the secondary healthcare level. It's the same functions. I mean, those functions have to be integrated. In so many countries, you have vertical NCDs programs, insulin, being it insulin or cardiovascular diseases. This is not cost effective. It will not, convince donors to invest in that. It's not sexy to speak about primary health care, but that's the most cost efficient and cost effective. So, and then maybe I will come back later because I think 6 minutes, but there are still some other ingredients in this approach which I think can be interesting for you, like the level of care issue and etc. But I'm sure it's more than 6 minutes. Isn't it? Well,
thank you, Erika. That was very passionate, but certainly comprehensive. And it's really great to hear the view from a donor. And I think some sort of key words emerging from your presentation. One, type 1 diabetes. How can we get this into the overseas development assistance or development assistance for health discourse? It's completely absent, as have been NCDs generally. Secondly, SDG targets 2030, we actually have 3 years, because in 3 years' time, 2028, you'll need to get the results to analyze, to publish them before the 2030 meeting. So there's not that much time left, and the results will not be achieved. So we know that, so let's start working on the narrative. Integrated advocacy, so integration again, advocacy at the highest level, to bring type 1 diabetes as part of the maybe NCD discourse, but actually the primary healthcare or universal health coverage discourse with an equity lens. And you gave a very interesting sort of 4-pillar approach to 4 pillars of a comprehensive approach: the narrative with an equity lens, policy dialogue, evidence space from the interventions on the ground, and a systems view, with primary care being the basis of provision. But coming to PPR, so that's pandemic preparedness and response. Actually, the language we used, and I had the privilege of co-chairing the health task force, was actually health threats. It was not COVID-19. Even though the task force was pandemics, we changed the narrative so that it was actually on health threats. So I think there's an opening there for the G20 meeting, because this year's G20 meeting is going to be in South Africa. It's an opportunity that must not be missed. So we next move to James. So we've had World Diabetes Foundation. Then we had the Swiss Development Agency. And now we have a view from a private foundation. James.
Thank you. Well, hello, everyone. I first want to thank you all for your contributions. I feel like I'm coming at the end of a really engaging conversation. I've been reflecting on a lot of side conversations I've had, but also the panels I've heard. You know, for me, I think we can walk away and think about the many challenges that we've talked about. Some of the providers in particular really walked through what are the up and down issues with treating people with type 1, making that sustainable, educating families. But honestly, I think the energy we have in the room here today and some of the solutions I've heard are what I'm going to take home. I remain really optimistic about where we are. I do actually think we're making a large change in the narrative about NCDs and how type 1 diabetes and our acute needs really fit within that discourse. Helmsley Charitable Trust, which I'm proud to represent today, is a US-based private philanthropy. We're proud to be one of the largest private philanthropies focused specifically on type 1 diabetes, and that's at the core of what we do. We extend a lot of our support as much as we can into low and middle income countries, but we know it's not enough, and I think this idea of global partnership and coordination is essential. Ultimately, my portfolio is tasked with trying to make solutions for what is the global majority of people with type 1 diabetes, especially if we improve survivability. So, you know, I really like Elsa's commentary on making sure we're holding ourselves mutually accountable, and some of the commentary from the previous panel about how our approaches are hopefully complementary, but I also recognize we need to be humble that there's effort to go in that direction. Helmsley works specifically to address the immediate urgent needs. I think there's been a lot of discourse about donation programs. The reality is that a lot of countries remain very far away from supporting all the people who need care. In sub-Saharan Africa, we're still losing 1 in 2 people living with type 1 diabetes because they're not accessing care quick enough. At the same time, I think we realize that there's a need to strive for long-term sustainable solutions that require systemic change, an advocacy movement like Dr. Anna Makumbi highlighted, and commercially sustainable markets that make it feasible for those products to be introduced by governments and suppliers in a collaborative long-term way. So I'm going to walk through some of the approaches that Helmsley takes to address these challenges, recognizing it's a lot. I think first, this theme of integrating care that a lot of the speakers spoke about on this panel and previous panels is really important for us. Type 1 diabetes will always be at a core of what Helmsley does, but we recognize that it does not reflect the reality on the ground. For people living with type 1 diabetes, for providers, for policymakers, type 1 diabetes is one part of an entire package, and we can't take that disease in a silo when we're thinking about interventions. Part of our approach has been investing in some of the work that Dr. Anna Makumbi described earlier called the PEN Plus model. That is really aimed at seeking and thinking through the question of how do we make sure type 1 diabetes is complementary to some of the existing interventions, like Erica's work on helping to fund some of the PEN interventions. WDF is also heavily invested in making sure that primary healthcare package of essential non-communicable diseases is growing, expanding, and sustained. But we also know that there are acute challenges for type 1 diabetes and other diseases like sickle cell and childhood heart disease. How do we package them together so that they have a lasting home within the health system? To Dr. Anna's point, there are many challenges and implementation gets messy, but I think we're optimistic in that direction. I think a lot of us also spoke about the ambition of local ownership, and Helmsley takes that extremely seriously. Country health systems are diverse and complex, and the visions that we have at our foundation do not always reflect the realities on the ground. We know that. I think we take solace in trying to find partners who really put country partnerships, government leadership at the center of what they do, but we always know that that's a journey that needs to continue forward. I think I'm comforted and encouraged by the fact that we've made a lot of progress with partners like the World Health Organization that's advancing technical products and normative guidance at a global level. We heard from Sanjana on the first day, as well as Dr. Kumavi in the Afro region. Together, we have a better sort of launch pad for us to think about what are the approaches we can take forward across regions and across governments. And those partners are working closely with governments to adapt and modify and implement that guidance. Third, I think Helmsley has played a unique role and will continue to put a lot of emphasis in terms of how we're investing heavily in empowering the voices of people living with type 1. Next week, we're one of the key sponsors of the NCD Alliance Forum. We're excited to be bringing type 1 diabetes to a large, broad umbrella to advance that advocacy movement, but also think through strategies about how people in affected communities can be really change makers within and across their communities. We also recognize the need for a more tailored, directed approach for the type 1 diabetes community. So provided seed funding to a mechanism we call the Type 1 Diabetes Community Fund. I'm really glad to see a lot of the partners from that in the room today. Welcome others to join that fund with us, because we know that getting money closer to the ground to those affected communities helps really address a lot of the challenges we talked about. Peer support, putting pressure on governments to work quicker, finding solutions that are maybe a little scrappier than we can devise at headquarters of my organization alone. So we need those community voices and actors in the fight. So I'll leave it there. I think for Helmsley, we're constantly thinking about how we integrate type 1 diabetes care, we empower and transition that care really to long-term government leadership and ownership, and how we make sure that the community and affected people are really a core part of that conversation and progress. But again, I remain optimistic.
Thank you, James. Yes. Thank you. It's great to have a sort of optimistic voice. And you stressed, we heard lots of challenges and problems, but I'm an optimist too. All of these challenges and problems are there to be solved. And we have an incredibly able group of individuals in this room and beyond who can solve these problems. I mean, you stressed the importance of mutual accountability and shared responsibility, which was actually the narrative used by the HIV community. Most of you are very young, not to remember this, but I was at the Global Fund as a member of the executive management team, and that was the narrative we used: shared responsibility, everyone's responsibility, and it worked. And the success story. Secondly, importance of systemic change, as with the earlier presenters. Then, use of strategic public-private partnerships to enable this transition in an orderly manner. And you talked about Helmsley Trust's three sort of areas of focus: integrated care, partnership approach, local and global level, and empowerment at community level. And be interested to hear more about the Type 1 Diabetes Community Fund. But after the next panelist, of course. Our next panelist is Stephanie Pearson, who is the Senior Director of Global Responsibility at the Breakthrough Type 1D. So Stephanie, the floor is yours.
Thank you so much. It has been a pleasure to get to know many of you this week in side conversations and getting to hear you speak. I've taken a lot back that I'll be taking to the executives at my organization. If you don't know us, we are Breakthrough T1D, which is formerly JDRF. We went through a rebranding this year, so many of you may know us at JDRF. We are historically a research organization. That is historically what we have done for many, many, many years. And we invest over $200 million annually in research to find a cure for type 1 diabetes. We are still committed to that, but recently, what we have decided as an organization is that is fantastic, that is what we're driving towards, but what are we doing today? How are we making sure that people with type 1 are getting the care that they need, not just domestically, but globally? And so we've really taken a look at our portfolio and started expanding into the global sector to contribute. And so we do that in a few ways. One way is when we started this journey, we're research and we needed data. And as we've learned today, there's not a lot of data that exists when it comes to under-resourced settings. So how are we going to make data-driven decisions to figure out what to do, where to go, where to invest? And we worked with many partners, including Life for a Child, WDF, ISPAD, to help develop the T1D Index. And that really helped us drive what are we going to do and where are we going to go. And so some of the initiatives that we work on is some pilot programs that we do to increase access to care in under-resourced settings. We work to increase diagnosis rates and early intervention. And then we invest heavily in what we call our T1D community, our advocates on the ground. And we do that because A, it matters, but B, we find they are our best resources to make the biggest difference. And then another initiative that we are heavily involved in, which we talked about earlier in the week, is this global access strategy that we're working on with CHI, Helmsley Trust, WDF, and several other companies that are coming to the table. And so as we've walked through this journey, our organization has also asked, okay, we're driving towards a cure, but we know if a cure came out tomorrow, we can't get it into the hands of anyone globally. So how do we fix that problem? And that's what we keep in the back of our heads every day as we develop interventions and programs and investment cases, is how do we build that road to where when a cure is found, we can get it into the rural settings out there very quickly. Thank you.
Thank you, Stephanie. It was very interesting to hear about the transitions that you've been going through from GDRF to breakthrough type 1D, but also from local to global focus, and also from cure in the future to care now, which I think is important. And it's interesting, it would be interesting to explore what drove that transition process, perhaps in the Q&A. What was that aha moment for you to make that transition? So thank you all to all the panelists. They've kept the time, so please join me in thanking them. So I now hand over to my colleague, Professor Jean-Claude Mbanya, to start a series of questions. Jean-Claude.
Thank you. Thank you. Thank you, Rifat. I think we've made great headways. But I want to narrow down my questioning to something very specific to the topic. We said that we are here to discuss how do we access integration, advancement in low resource setting. So my next intervention and next question to the four of you, we don't mind about the challenges and the barriers. I see challenges and barriers as windows of opportunities for us to act. So I like those opportunities. So I have two questions for you, which is very easy. So what types of country-level programs in type 1 diabetes would your organization support in low-resource settings? And that's important to me because I want people to live from here knowing what you can support and how they can tease into your levels of support. I will start with Erica.
First of all, I have to say that we do have huge budget cuts, so that is said. And, well, I already mentioned some. First of all, it's not in a country. I cannot say we will support entities in that country, because as I said, what is interesting is that it still remains, the investment makes sense if there is a return, and if it's a cost of transaction, are acceptable for us. So we would never start a project in just one country and just delivering, like, we are not a luxury NGO,
Although you are Swiss.
Yes, we have to combine. So whatever we do, there are friends from Tanzania here. We have a huge health portfolio in Tanzania, Ifakara, and etc. You know about this. But it's never in just one country. because I cannot, because there are, for example, when it comes to human resources for health and linking the medical education system, being it in NCDs or communicable diseases, and the market, you have to go with a regional approach. Otherwise, you cannot address these issues if you go country by country. If you want it to be very cost efficient and to transfer some knowledge, some good practices, you have to go for a regional dynamic. That's what we did in Central Asia with the support of David and the University and Geneva hospitals. I mean, trying to have a kind of comprehensive approach when it comes to integrating NCDs within a health system strengthening approach, primary health care at the center in Eastern Europe and Central Asia. So first answer, not just in one country. Then we have to combine actions. I need evidence, and for you to be, this is not just about delivering, care. It's important, but at the same time, you face a lot of huge bottlenecks if you don't address normative and, legal issues. Let me give the example here of fiscal norms and, like salt taxes and etc. The entire, for example, in Eastern Europe, legislation around mental health, huge psychiatric wards at the hospital level. You cannot address this just by implementing projects in the country. You have to go at WHO level, trying to influence, the guidance and guidelines and arrangements on the number of psychiatric beds in one country, and the same for fiscal norms and etc. So you cannot just say, I'm going to do this in Tanzania or in Cameroon, and then, okay, we deliver what we can deliver. So you have to combine it with policy issues. You have to make sure this evidence feeds that you are present in UN fora with your evidence and your advocacy work. And we channel this, we channel this evidence, our own evidence in these countries, but we are all open to all sorts of evidence which, feeds the kind of policy dialogue and normative and norm setting we can carry out at the global level.
Thank you very much. I think you can clap for her. I think it's important. It's important that when we leave this place, we should not think that it's only country-level programs. We have to try to get regional programs together and then influence people like the Swiss and the rest to take all this to the G20 so that we can support the program. I'll ask a different question, and this time it will go to Stephanie. From your experience, what should low and middle-income countries be doing in type 1 diabetes to achieve the global diabetes treatment coverage targets?
Simple. Wow. That's one. Oh, my goodness.
I thought I can surprise you. That's why I asked you first.
You got me good. For us, I think it really comes down to A, collaboration, being willing to collaborate, B, helping us understand the needs, right? Helping us understand what do you need for access? What do you need to make those advancements? And then for 3, helping us build that pathway. For breakthrough, it really is all about making sure there's a pathway so that low resource settings can get that access that they need, so that one day when we have that cure, which we are closer than ever to that cure, we can get that quickly to you guys.
Thank you. I'm always thinking of breakthrough in my life. I'm still waiting for a breakthrough. So you see.
I know. We're close, I promise.
So the rest, the two of you, I'll ask differently. You have 2 questions for each of you. The first one is about the types of country-level programs in type 1 diabetes, which you would do in low-resource limited countries. Then the second question, which will be for the last 2 of you, from your experience, what should low and middle-income countries be doing in type 1 diabetes to achieve the global diabetes treatment coverage targets? You know why I left the 2 of you last. Elsa?
Thank you, Jean-Claude. As you know, at the World Diabetes Foundation, we actually focus a lot on country implementation, but we don't forget the rest, and both the regional, the global advocacy is also part of it. I just wanted to make that clear to everyone. But going back to your question on country-level program, as you know, the World Diabetes Foundation doesn't fund medicine, so it goes without saying that when we do a country-level program on type 1, we make sure that other donors are there to actually provide insulin. That's the first important thing to highlight. And then we will focus on other aspects that have been mentioned by the practitioners, by the people living with diabetes. It's the capacity building aspects, both for the health system, but HCPs, but also for patient education. We are also increasingly looking at the digital health aspect in terms of having the data, in terms of more general EMR system as well, and also some of the governance mechanisms that are needed, whether it's through having NCD coordinator at the district level that also include type 1 diabetes in their work. So that's the kind of the main components. And I think at country level, what we're also increasingly doing, and with donors that are on the table here, it's leveraging other funding. We've just heard that SDC does not support country level as such, but we are co-funding a Swiss organization in some countries that is actually working on NCD care. We have a similar example with Santé Diabète. They received funding from previous panelists from Life for a Child and from the French Development Agency. And we are, so I think leveraging funding at country level is so important because we all have limited funding, but together we can achieve a lot more.
So actually, when you go to a country, you do that country program, you don't bring your programs in. Do you edge towards the country program or towards your own program? Because countries have specific needs. When you go to a country, do you access their specific needs and work on their specific needs, or you bring your program in?
I know you know the answer, but I will make it explicit, because obviously we work based on local needs, right?
Yeah.
So we don't have our own programs. And the type of support that we'll do will differ from one country to the other based on the actual needs, and also based, and most of our partners, they are local partners, and they know much better than we do what's actually needed. What we can bring is more that understanding of the donor ecosystem, and making sure that they can actually leverage the necessary resources.
So do you come together, and that will come to you too, James, as a consortium with different partners and bring that to the table, to the government, so that they would have a greater pocket? Because what we see right now is that it's just opportune sponsorship. This one has this one has this, and then I have to say it here, every donor goes to East Africa. I don't know whether because they like safari or what, but but we need to be able to stratify them in such a way that it is distributed evenly. Is that what you are trying to do?
Yeah. Back on the East Africa, West Africa, both of us, we know that there's more also of a language and issue that for many donors it's just easier to work.
I speak French and English, and if you
if
want me to speak Danish, I will be able to speak it if the funding will come.
No, but just to say, we all know that coordination is easier said than done. And then each donor might have some, of course, some program with some cycles. So sometimes it's actually quite difficult to just meet at the same time and say, we go and support that. But going back to the mutual accountability, it's also having strong partners also at the ministry coordinating. And we all know there are some power dynamics also included in that. So how do we manage all of that? And we always go back to the national ownership and leadership.
Okay, James, I know that you have some good news for us here.
I'll try. Yeah, I think Elsa's comments really resonate with me. I think in some ways there's a reality that we need to manage our own programmatic approach, our own limitations as organizations, both financial but also operational. But I think increasingly what I'm seeing in the type 1 diabetes community, including the funders, I know funders can be a source of chaos amongst ourselves, with NGOs, with governments. I've been on that side, so I certainly understand it quite well. I think we're seeing a lot of momentum and intentionality, including with the initiative that Stephanie highlighted, where we're trying to convene each other and think through a shared strategic framework to prioritize based on different country archetypes. We heard a little bit about that on Tuesday. Specifically about country and low resource settings, I wanted to share a story in which you know, Helmsley's approach was very much informed by other donors. A couple of years ago, WDF was actually in a prior funding cycle in terms of how they're going to structure their investment in Malawi. We knew that our investment was shortly thereafter in our next cycle. So we took the opportunity to go in country and understand what are the needs in country, what does the government prefer to do? And I will admit, I started that trip with my own assumptions and biases, my own program and vision and what I thought was going on, including with Penn Plus. And I think where that trip was really beneficial is I was able to come together with folks like Sana, who I see in the back, and Mads, who is supposed to join me on this, to sort of hear their experience and perspective of working closely in the country, including in areas where Helmsley doesn't work. So a longer focus in Penn and type 2 diabetes care, primary healthcare level work, and how that can complement some of the training and mentorship programs that Helmsley was trying to advance through the Penn Plus initiative. UNICEF joined us on that mission, and I thought we had a lot of thoughtful discussions, including with leadership at the ministry. I'm confident, and I'm sure the folks from Malawi in the room can tell me that our work is not perfect, but I again remain optimistic that we're really reaching a place where we're finding each other's complementarity and working in line with what is ultimately the prioritization of NCDs in Malawi, the operational strategy that they've developed for those programs domestically, and trying to fill the needs as best we can, recognizing our own limitations. And today, WDF, UNICEF, and now the Scottish Government are key funders together in that shared initiative that's been led by the government in Malawi. And despite being one of the poorer countries in Southern Africa, they're really leading and at the forefront of this Penn Plus movement and are being a regional catalyst despite their lack of resources. And that goes back to this idea of mutual accountability and working together gets us a little bit farther.
Yeah, I like that very much. What I wanted actually to hear, especially from you, James, is that you look at the global coverage estate targets.
Yeah.
And you say, okay, I'm going into the country. This is what I'll put in place so that you achieve those targets, so that when you are looking at the index of achievement, then it's going to be satisfactory. So how do you measure your success?
It's a great question, and I'll admit it's something that we're trying to improve and refine ourselves. I think first there's a reality that we rely heavily on the human impact stories we're hearing. The story I asked for explicitly from Christine earlier a few days ago was to really hear like our small investment with Sonia Nabeta Foundation is ultimately having a massive impact because of individuals are advancing one-on-one impact with each other. And that goes back to that idea of investing in community-based organizations. At the same time, I think there's a larger public health approach that we're trying to align on with our partners. We're funding investments, including with the World Health Organization, to think through how we improve monitoring and surveillance standards for both a PEN and really type 2 diabetes lens, but also increasingly a PEN Plus monitoring and surveillance framework that hopefully we can align on internally as Helmsley, but also work with countries to start implementing and improving how they strengthen their surveillance and monitoring. So I will say it's a work in progress, but data is certainly top of mind.
But that's very good, because work in progress means that we'll measure how you've progressed along the lines when we meet again next time.
I hope so.
And Erica, I just want to make a statement so that you know that you have a lot of responsibility. USAID is leaving the international scene, so means you have to go and encourage the Swiss not only to give money to David Barron, but give to the rest of the world, and even more. Rifat, I think you have 2 more questions to ask.
Well, it's a perfect segue to my questions. My first question is, with the current changing landscape, no names mentioned, of global development funding, which might be the implications for the international support towards type 1 diabetes care and wider NCD programs? So I think this is a question worthy of interventions by each of the panelists. And shall we go from right to left or left to right?
I think Rifat, you just asked your 2 questions so that I can
Well, let's take the first one because the second one is very, very specific. Because I'd like to challenge the panelists, which I'd like to do for the second one. But the first one is also challenging. So let's start from far right.
I don't want a question. I want to challenge Jean-Claude. So, Jean-Claude, on est encore en train de, I say it in French, on est encore en train de mesurer l'impact du retrait de USAID. So it means that it has, of course, it has consequences on our own programs because it's not that we co-finance directly, but yes, some projects we co-finance, but others, of course, if you cannot operate in a country, then what is the role of the Global Fund of delivering, consumables? So we are still trying to figure out what it looks like. But I will say, I'm not optimistic, I am hopeful, which is quite different, because hopeful means there is hope, and not in a confessional way, but you want to do something. Optimistic, for me, in my view, it's more static, So being hopeful, hopefully means that I do think that there will be, I was, hoping that the COVID-19 would have contributed to reshape the global health landscape. I'm very disappointed. It didn't happen. I mean, it's even more fragmented now. A lot of funds, new funds with mandates which are at some point, are redundant between different agencies and etc. So a donor is completely lost and having to choose between, malaria, cholera, and so it's very complicated. But I do think there is an opportunity to reshape the space now because we have less money.
Which is the second question, which I'd like to come back to. So please bookmark that and think about it. That's going to my second question. But let's take the interventions from the rest of the panelists to the first.
I mean, I think we know the global landscape for health has changed dramatically in the past couple of weeks. What that means, I think we're still trying to figure out. We know there are going to be massive gaps. What those gaps are, we don't know yet. But we know they're going to be devastating. We know this. From a funder perspective, we're looking at what are those gaps going to be and how can we quickly fill in holes that need to be filled. We're not going to be able to fill in every hole, we know this, but what can we do as quickly as possible?
Okay.
Thank you. I just wanted to maybe look at what can be done also at national level because there's, what has already been said, but also taking on some example I've heard the last 2 days. I can't remember from which country they were saying that they managed for children to get the insulin covered, but through the school health program. So saying that they didn't go through the Ministry of Health, but looking at other potential sources of funding. So we need to think also maybe differently. Well, the Global Fund, we don't really know, but there was also another example that even at the Rwanda Diabetes Association that managed to get community health insurance to cover 80% of the insulin, if I'm not mistaken. So of course, there's the global, the funding situation, but there's also so many initiatives that are being taken at country level to actually maneuver around those funding issues. And again, more than ever, we need to be extremely efficient in the way we use resources, and that's where obviously donor coordination is even more important these days because there's no resource that can be further wasted. Yeah. Thank you.
So, James.
Yeah, I think the first day of meetings of pre-conference, they were using the phrase elephant in the room quite a bit. I feel like our news apps have been the elephant in the room this week. I agree with Stephanie. There are really significant uncertainties about what this means. At the same time, I know that Helmsley remains committed to our vision and mission of a world where people with type 1 can lead long, healthy lives. I'm confident we'll encounter more significant challenges, but I think to Elsa's point, it puts a greater onus on us to make sure we're using resources efficiently. When we're thinking about reaching those 100% targets, there's a real reality that we could be working a little bit more closely in order to determine how we introduce products sustainably. Are there guidelines in place? Is there an operational strategy from the ministry to scale up, training and disbursement of that? who is supporting supply chain, how are we leveraging that on a regional level to inform market dynamics. These strategies exist, and I think for a long time we've had a luxury of sort of attacking them in a bit of a fragmented way. But as sort of the envelope tightens, we need to be thinking more specifically, how do we coordinate on type 1 diabetes issues? At the same time, I think a lot of donors remain in the space that are committed to advancing larger health systems issues that extend beyond type 1 diabetes, and maybe we haven't done a good enough job of linking with those, elevating our needs. When we think about things like regulatory frameworks or coordinated procurement mechanisms, these are things that extend well beyond type 1 diabetes. So if we're taking them seriously, we need to invest time in sort of engaging with those broader, multinational efforts. So a lot of uncertainties, but I'm again optimistic that I think we'll find a way forward.
Well, yeah, I think that's a nice segue to my second question. Given the imminent shortage of funding and the uncertainty regarding the future and the existing fragmentation, which is a major problem, not just for type 1 diabetes, which I think is problematic, but also for global health generally. Again, being optimistic and hopeful, what kind of mechanisms could be developed at global level to address the forthcoming challenges, or not even forthcoming, that are here now in relation to funding? So maybe we'll start with James and move.
Yeah, it's a tough question. First my mind goes to sort of challenging the idea of how effective large global institutions are in this current context. And I think to Elsa's point, why do we need to be focusing more at a national level? How can we improve and take this moment to sort of recognize really the ownership and leadership of governments who are responsible for their own people? I see my job as trying to enable and overcome hurdles towards that ownership. But at the end of the day, I need to sort of relent to their leadership and guidance on where I should go. The other solution I think we've mentioned a few times is I think we need to be tighter amongst ourselves as donors, communicating in ways that maybe were ad hoc before, need more close structures. I don't know that we need to make the new global fund or anything like that tomorrow for type 1 diabetes, but we certainly need to have a stronger coordinating mechanism to make sure that when we're devising plans in our headquarters, that they are aligned with what those governments need and want, frankly. So not all the solutions, but I hope some of the ideas.
Yeah, no, great. So, but potentially at global and local level. So let's try and unpack those a little further.
Thank you. I think I echo what has just been said by James. I do not believe that we need a heavy global mechanism. We have a lot of existing and good global mechanism. We just maybe need to be more agile in how we translate that into implementation at country level. So, and this can be done in an coordinated but still informal way. It doesn't have to be necessarily through a global heavy mechanism. Yeah.
Okay, so you're saying local rather than global.
Yes.
Yes. It will continue to go right. Yes.
I agree with what was just said from both individuals. I think that enabling government at both the national level and even a regional level to take more ownership, we are enablers to do that. That's what we're working towards. Two, we need more coordination. And I agree, it may not be a global fund, but we certainly need to be coordinating our efforts among each other.
Okay, so Erica, it will be useful to also have some sort of examples of how this can happen on the local level. I mean, I don't want to sort of intervene. I will after you comment, but some specific instruments one could use, for example.
I think less is more. This is our motto. And instead of filling the gap, I'm not convinced about filling the gaps now. I'm not sure this is the solution. I would say let us together defragment the global health landscape. We have this opportunity and try to rationalize. We are in that move, actually. We try to bring partners together. For example, all product development partnerships we do have in Geneva and in Switzerland, including FIND, MMV, DNDi, for those who know. They have a complementary mandate, but they go, they reach the donors one by one, and it creates further fragmentation. So we are trying to bring them together and say, for example, look, can you please develop just a common narrative? You explain you are that part in the malaria landscape, you do this, you do the diagnostic, you do this, and you come with just one credit proposal to the SDC, and we will help you, for example, to develop the PPR argument, in relation to that. Malaria, HIV being amongst pandemics, of course, even if it's not obvious for most of the donors. You see what I mean? So rationalize, bringing it, trying to see which mandates are overlapping, how we can focus, how these agencies can be complementary and not be in competition. But it requires a lot of donor literacy, and a lot of accountability literacy, and everyone has to agree on that less can be more, actually.
Yes, but I think donors have been quite literate for quite a long time. I just want to challenge you. I was a donor at the Global Fund, and we're investing very substantial sums. I chaired the Phase 2 panel. We're investing about $5 billion a year. We prioritize country ownership. And there are many instruments that have been around for a long time. So my question is, will donors really make the transition from being donors to partners on the ground? Because to defragment, donors need to act. I don't think the problem is at country level. Of course, we need country leadership. So we have national health plans. So Kyrgyzstan was mentioned. I remember using MANAS, a very successful program that many donors funded. Pooled funding, Ethiopia, Mozambique, use that. I'm just using countries that were mentioned. Bangladesh, actually, was quite advanced in that. There are sector investment plans or sector-wide approaches. There are budget transfers, and we could go on. So is there a willingness in the donor community for type 1 diabetes to invest in these instruments? I just want to challenge you.
I think some of your prior comments sort of struck in me and Erica's as well, that I think in some ways less is more. You're citing examples from the infectious disease space where I think the reality is very different. Of course, on the global financing landscape, sure, but there are some really fundamental issues that are remaining an issue in the type 1 diabetes space. And mainly, if we look at some of the country representatives that have spoke about their programs, these are people managing massive portfolios, diseases well beyond type 1 diabetes, managing a ton of partners, and often with very, very limited staff.
Yes.
So instead of creating large sort of coordinating mechanisms at a global level, I think we need to be careful and maybe rethink how are we just investing time in additional staff capacity, seconded staff at ministries of health, improving technical working groups at a basic level that have been really highly effective in how HIV, TB, malaria programs are rolled out. It's because they have active coordination led by the government on an ongoing basis. It's not sexy, as a few people would say, but it really does genuinely make a difference to unlock some of those barriers. That's some feedback I'd provide there.
Yeah, I think each of those instruments are actually at country level, so they could be utilized effectively. So I'd love to hear the World Diabetes Foundation, which brings many actors together, of course.
Yeah. No, thank you very much. As you rightly said, there are a lot of mechanisms at country level. At the World Diabetes Foundation, we do not have the mandate to, let's say, do budget support or health sector budget support. This is not within our mandate. Having said that, we are trying increasingly to have at country level, you have a health sector coordination group where both government representatives and donors are at the table to make sure that our local partners are also included in those groups, that that's one thing for the coordination. We're also increasingly, you mentioned the Global Fund, the country coordination mechanism. Yes. We're trying increasingly, because for many years the NCD department was not included in those meetings. So that's also another entry point to make sure that they sit at the table. So for sure, there are many, but I think going back to the point on donor literacy, I think it's more maybe for local partners. Donors are literate because they're donors, but how we make sure, how we bridge in terms of the funding and making sure it gets into the local partners as well.
Yes.
Thank you.
Excellent. We could go on. I think this is such an important issue, but I think that there is, we can be optimistic and hopeful, because I think that there is some opportunities that can be had, especially at local level. I want to open the floor to questions, and I'm going to ask my colleague Jean-Claude to moderate this. Thank you.
Any questions from the floor, please?
Yes.
This is your opportunity to hammer them with a few questions.
18 minutes.
Any questions? You are hypoglycemic. You all have cerebral hypoglycemia. Yes, please. A question there. Another one. Then I'll start calling names.
Professor Bishwajit from Diabetic Association Bangladesh. Could you please picturize the world of type 1 diabetes with or without donors?
Another question from the floor, and you just think about the answer, please. Any other question? Oh, thank you. This is nice. It's nice to be the last session, because then everyone is asleep. Please, can you answer his question?
The question is, if without donors, picture the...
Yeah. Can you manage type 1 diabetes in countries without donors? That's what you mean.
Yeah.
But they're all donors. You're asking the wrong people.
I mean, truly, I wish that wasn't the case, that donors are necessary, but we're in a position where we are. But again, I want to circle back to this idea that that picture is going to look very different based on where we are. For some countries, there is a very tall hill to climb to be self-sustainable. But I do think there are countries like Bangladesh that are doing quite well and really have an opportunity to increase their ownership and prepare for a reality that some of these programs, as we were discussing in the previous panel, have commitments to 2030. What does that mean? And really, how can we prepare now for that reality? So I'll say it's challenging. Arguably, there are not enough donors, and we're missing a lot of children with type 1. But I also think that there's a lot of hope maybe in countries, and many of them represented here have quite a close path towards taking charge of that, in my opinion. But welcome opinions from others.
Yeah, I think I would be happy if it's without donors. But I think there is not just funding, it's about also, moving the NCD's agenda forward. As I said, making sure that from our side, in every single UN normative and regulatory fora, we bring this issue about the NCDs being part of the Agenda 2030. It's just, not just your country can do it, because they are part of this constellation, including WHO. But if you think about all these member states coming together and trying to foster much more commitment from member states and from donors to move the agenda forward, then it's at your benefit. It costs nothing. It's basically, our salary. So it's even not an investment, a funding investment. It's about just our role as member state and international cooperation representatives.
Thank you. Any question again? Yes, please. 2 questions. I thought I would ask more questions, but you've catapulted me. Yes.
I'm Raul Bermeo from UNICEF at our headquarters in New York. Just building on that last comment of the importance of engaging in kind of international cooperation discussions with member states, just flagging that, we have the upcoming high-level meeting on NCDs and mental health in September. I think is a once-in-generation opportunity to make sure that children and young people are really at the heart of the NCDs and mental health agenda. And it has not always been the case that these childhood onset NCDs, including type 1 diabetes, but there are others, sickle cell disease, congenital heart diseases, for example, are really at the core of that narrative, the global narrative on NCDs. So I'll turn this comment into a question now, is how are your agencies, organizations, institutions engaging in that process? It has now started. And how can we coordinate around that to make sure that we have kind of a common vision that that political declaration that will come out and will really change the landscape around NCDs, that it will not ignore children this time around. Thank you.
Who wants to start, please? Elsa? I come from Africa, where dictators, I just...
Thank you, Jacques. And thank you, Raoul, for the question. And as you know, at WDF, we're also very much thinking in terms of this high-level meeting coming up in September, and we have a clear roadmap with different events leading up to the high-level meeting. We do work on type 1. We do not have a specific entry point that is children, but this will be, of course, part of the whole advocacy packages. We have talked also with other division within UNICEF regarding food system. The Nutrition for Growth Summit is coming up. There are many other entry points with maternal health event where we want to have hypoglycemia in pregnancy highlighted. There's the World Health Summit. So yes, as you know, together with Ben, we're trying to have a broad entry point to bring the NCD, both prevention and care, up to the high-level meeting. Thank you.
Erica?
Yes, as a member state, of course, we will advocate for the resolution and the declaration to be very comprehensive. What worries me, I already have headaches about that, is that there will be, I'm quite sure, a point on funding, and because now, starting since the COVID-19, every single resolution or normative or whatever comes with a paragraph on there is a need to have a new funds to implement this resolution. And then I will start to be disappointed, because then we start again with the competition and fragmentation. So I will fight for that. We will be there. It will be integrated, mental health, all NCDs, coming together, primary health care at the center, etc. But that paragraph, specific paragraph, already starting from now worries me, because that will be the point where there will be a fight between countries from the south and countries from the north, which will say, okay, now it's a resolution, it's not a funding arrangement, it's not a negotiation on who is going to fund what. But then on the other side, I also understand, there is a resolution, there are a couple of issues to be addressed at the country level, but then where comes the fund from if it's fragmented, including at the country level, you see? So but yes, we'll be there. We can discuss about this if you want. What is your name?
Okay. Thank you. Suzanne, you have the question. Then the last one would be from you.
Okay, thank you. I want to, first of all, to thank the organizers of this meeting, because it's really the first time when we see funders, policymakers, community of patients, academicians in the same room to discuss. And my question to funders is, who is your vis-a-vis for discussion? Is it possible for community to reach you? Is it possible for academicians to reach you? Or you discuss only with governments and this makes things more difficult to have results on field? This is my question.
I will just start from Erica and all of you would answer. So Erica, if I want money from Swiss, I should just reach you. But you have to give me your phone number and your email address.
David knows I never go around with visit cards. So, no.
Just answer the question.
The question is,
I'll ask David for your contact.
Yeah. C'est terrible. Vous êtes terrible, vraiment. No, but, I was talking about different instruments, project at the country level, UN organization, contribution to UN organization for the normative work, including WHO. Then I was talking about global partnerships on research. So in our institution, it's a small institution, but we have the luxury of having many instruments with high cost of transaction. You see, but that's the beauty, it's the added value of the organization. It's still a technical agency. It's not just about money. You know, it's also about, peer exchanges and etc. So within our programs, there is always a research action component. David knows about it. We had many projects in Central Asia, in Ukraine, and now with this global initiative. So there is always a research component. And then David and the University of Geneva, they are the implementing agency, and they make sure they bring that expertise on board. Now, when it comes to the multilateral work, this is a very, it's a very formal posture where we would go there at the UNGA. It's just one person. It's not even two. It's one person at the high-level meeting. And then, of course, we prepare it with the other, including because we represent Switzerland. So we have also to ensure coherence with what we do in Switzerland. Otherwise, you could have been accused of schizophrenia. So it's very important. So there are a lot of stakeholders which are aligned along these different instruments. So it's included, but to answer, I mean, I'm coming back to your question. I mean, how we can support you individually, for example. Is that the question? Or your organization, where there are not so many instruments. There are mandates and contributions. Mandate, they go with a tender, and contribution, they go for large institutions which contribute 50%. So I hope I have been clear, including for you, Jean-Claude.
She will never contribute 50%, don't you worry. Stephanie.
I think for our organization, we work with anyone and everyone from top government to a newly diagnosed person wanting to learn to advocate in their home country. We're not off limits. We're very accessible, and feel free to reach out, and we're happy to discuss anything.
As I already know your answer, everyone can apply.
If you say so, no. But that's true that different type of stakeholders can apply for funding at WDF, whether patient association, community organization. So it's a wide range. In terms of, since we've been mentioning research, we have an increasingly focus on implementation research, but ideally we believe in the strengths of having application coming from a wide range of stakeholders at country level to make sure that all parties are well represented.
Thank you.
Yeah,
James.
It's a great question. Helmsley is an invitation-only foundation, so we typically try to network and create connections that align with our strategic approach. When we do have funding openings, we publish those on our website. Most recently, we closed a funding opportunity for the Type 1 Diabetes Community Fund. There might be another opening later at the end of 2025, so please look out for that. In terms of grantees, we try to have a really diverse approach with our grantees, ranging from small local nonprofits to large international ones, academic institutions. We typically do not fund governments directly, just based on our restrictions as a foundation. But again, try to find solutions in which we can partner as closely as possible. So that's where a lot of the work gets done. So
Thank you very much. The last question from the floor. He moved from the back to come right here,
Yeah, thank you. Zoran Stojkovski from Macedonia. As a patient organization of associations of people with type 1 with diabetes in Macedonia, one question for all of you. How much you provide funding for establishing a control system related to bigger accountability, transparency of any of the actors involved, including business sector, including governments especially, related to the issues of securing insulin, securing equipment, because I think that this is, in my view, something that is missing, and correct me if I'm wrong, how much your agency or foundations are supporting these types of causes, especially partnering with, hopefully, us as a civil society organizations that can influence. For me, this is quite important issue, considering that as a result of criminal activities, corruptive activities in the government, we are getting really low quality.
That's what you said the other day, that poor quality corruption makes sure that you don't have the right insulin. So are you asking them how much money they are putting or whether you are writing a program?
Are they?
Yeah. Are you in terms of corruption, in terms of equity, do you invest in such programs?
Yeah, thank you. And I'm glad we're one of your supporters. Helmsley invests in a few accountability mechanisms. Like I said, a large supporter of that in-CD Alliance community, which we feel is important for holding grassroots level accountability towards organizations. That includes some funding to improve how those alliances are engaging in policymaking reforms. We also invest in mechanisms like the Access to Medicines Foundation, which are working to hopefully fairly evaluate how the largest pharmaceutical organizations, diagnostics, and increasingly generics and biosimilars are offering access schemes. We've had some smaller investments in areas like UNDP, which are focused on a few areas, including investment case and some look at anti-corruption measures in Malawi and Uganda specifically. So a little bit, but it's a challenge for sure.
Anyone with an answer?
Every single project at the country level comes with a governance portfolio. So, and we work with Transparency International and with local, for example, in Bosnia and Herzegovina, with patient associations, human rights watchdogs, and etc., especially in Eastern Europe and Central Asia. North Macedonia, we don't have a health project, but in Ukraine, I think it's a very good example of transparency when it comes to procurement. We work with everything is online, and there is a watchdog patient association also having, a kind of supervision role, and it's full part, because we work with Swiss taxpayers' money, so we are very, very exposed. We cannot take that risk of not addressing that.
Thank you very much. Professor Atun would now give a concluding remark, and then after which we'll go for Ben.
And it will be very quick, 30 seconds. It's been very rich, varied and frank discussion. I won't attempt to summarize it. You all need a good tea or coffee. But we identified many challenges, but we leave you with optimism and hope. And please thank me, our panelists, for that.